Welcome back to another video in our oncology series. We're through with the emias, on to the omas. This is the first of two sketches on lymphomas. And if you can't tell already, things are about to get magic-y. Magic-y. It's a word. We're going to start with Hodgkin lymphoma at the Great Hall and finish up with non-Hodgkin lymphoma in our next sketch at the Magic Shop. So on that note, welcome to Hodgwarts. As you can probably guess from the name, lymphomas are cancers that involve lymphoid tissues. At Sketchy, a crowded chessboard is our symbol for lymphoma. Imagine the board as a lymph node, where B cells and T cells interact and mature. Kinda like the white antibody archers and T cell knights interacting on the board here. Notice too that we've drawn an abnormal proliferation of white antibody archers, kinda like an abnormal proliferation of mutant antibody secreting B cells. In fact, Hodgkin lymphoma stems from a single mutated B cell. The B cell isn't born mutated, mind you. It pops out of the marrow mutation free, floats around in the blood for a while, then hits the lymphatic system. It's here that we start to have problems, specifically at the germinal center of a lymph node. The germinal center is like a warehouse party full of B cells just getting lit and rubbing up against each other, interacting with helper T cells, proliferating, differentiating, and most importantly, mutating, so that they can make more selective antibodies. A germinal center will be represented by an owl nest. Think of it as a place where owls proliferate. Besides the lymph node, other sites of lymphoid tissue contain germinal centers as well, like the liver and spleen. Hodgkin lymphoma can arise at any one of these sites. Most commonly, it's a lymph node, however, and disease usually spreads in a contiguous stepwise fashion, moving from the original lymph node to adjacent nodes within the same local group. Hodgkin lymphoma most commonly occurs within the cervical, supraclavicular, or mediastinal lymph nodes. That's the neck and chest, which is where we've placed this chess enthusiast owl friends. Huh? What's that? Why the owls, you ask? Wait, you haven't read the books? Oh, come on. Do you have a single childlike bone left in that cold, stony, emotionless husk that you call a body? This is going to be a long sketch. Well, the mutant B cells of Hodgkin lymphoma can be identified by the presence of Reed-Sternberg cells, those classic owl eyes, which we'll discuss a little later. There are two types of Hodgkin lymphomas, classical and nodular lymphocyte predominant, with classical by far the most common, and the main focus of this sketch. Nevertheless, we've drawn in the banner for House Lymphopuff on the right, representing the rare nodular lymphocyte predominant type. On the left, Professor Hodgkin's slug node embodies the so-called classic Hodgkin lymphoma, and up above is the banner for House sclerosing, which should remind you of the most common subtype of classic Hodgkin lymphoma in the United States, nodular sclerosis. In developing parts of the world, the mixed cellularity subtype predominates, embodied by one of the House Hodggoblins mixing today's meal. There are two other rare subtypes of classical Hodgkin lymphomas that will not be making an appearance in this sketch, and that is the lymphocyte-rich and lymphocyte-depleted varieties. Classical Hodgkin lymphoma has a bimodal age distribution with the initial peak around age 20 and second peak around age 65. The majority of patients that are diagnosed are young. Hodgkin lymphoma is more commonly diagnosed in males, though the classic nodular sclerosis subtype of Hodgkin lymphoma is most common in females. Patients with Hodgkin lymphoma are usually asymptomatic. However, there are a few classic symptoms that can help lead you towards a diagnosis. One of the most common presenting symptoms for Hodgkin lymphoma is painless lymphadenopathy, which is why we've made this kid with the owl nodes, well, smiling and pain-free. The cervical and supraclavicular nodes are commonly involved, and it may look like the patient merely has lymphadenopathy from a viral illness of some kind. Even though they cannot be palpated, mediastinal lymph nodes are typically enlarged as well. In fact, Hodgkin lymphoma may be found incidentally on chest x-ray. A large mediastinal mass is the second most common presentation of patients with Hodgkin lymphoma, and they may not have any symptoms. A large mediastinal mass would clearly require more workup. Patients may also present with B symptoms. These include fever of over 100.4 degrees in the previous month, recurring drenching night sweats in the last month, and unexplained weight loss of greater than 10% in the past 6 months. B symptoms are most common in more advanced stages of Hodgkin lymphoma and usually correspond with a worse prognosis. Pruritus is a common early symptom of lymphoma and can even present months or years before diagnosis. And lastly, a rare but nonetheless interesting and highly specific presenting feature of Hodgkin lymphoma is alcohol induced pain. Yep, it's exactly what it sounds like. Less than 10% of patients experience pain following alcohol ingestion, typically at sites of bony involvement or lymphadenopathy. Weird, right? The mechanism is unknown. Maybe just take it easy on the butterbrew there, Hudgmini. Epstein-Barr virus is probably one of the most commonly associated viruses implicated in the development of both Hodgkin lymphoma and non-Hodgkin lymphoma. EBV is an oncogenic virus that can alter the growth of B cells. And it turns out that a significant fraction of Reed-Sternberg cells have genetic alterations caused by EBV. The crutch is our recurring symbol for immunocompromised patients, such as HIV positive or transplant patients who are at a high risk of acquiring this virus. In fact, immunosuppression associated Hodgkin lymphoma is almost always associated with EBV infection, though viral infection is probably only part of a complicated multi step progression toward malignancy. Patients who have congenitally acquired immunodeficiency diseases, are undergoing chemotherapy, or have had a recent organ transplant are all at an increased risk of developing Hodgkin lymphoma. The white wizard hat is our recurring symbol for HIV, who we first met way back in Sketchy Micro, the evil HIV wizard. Hodgkin lymphoma is a common malignancy in HIV positive patients. Most HIV positive patients with Hodgkin lymphoma have a co infection with EBV and tend to develop lymphomas early in HIV infection. They typically have less favorable subtypes and poorer prognosis than the general population. All patients with suspected Hodgkin lymphoma and risk factors should be tested for HIV. There are also a number of autoimmune disorders that are associated with an increased risk of developing Hodgkin lymphoma. These include systemic lupus erythematosus, rheumatoid arthritis, and sarcoidosis. Genetics may also play a role in the development of Hodgkin lymphoma. Studies have shown that there is an increased risk of developing Hodgkin lymphoma in patients whose family members have the disease. This may be due to a shared genetic susceptibility or exposure to the same infections. So get that family history. Socioeconomic status may also play a role in the development of Hodgkin lymphomas. Patients with high socioeconomic status are at a higher risk to develop classical nodular sclerosis Hodgkin lymphoma, the most common subtype in the US and Europe. Patients with a lower socioeconomic status, on the other hand, are at a higher risk of developing classic mixed cellularity Hodgkin lymphoma, the most common subtype in developing countries. The reason for the increased prevalence of mixed cellularity Hodgkin lymphoma is unknown, but it has been speculated that patients with higher socioeconomic statuses may have less or delayed exposures to infectious or environmental agents linked to certain lymphomas. Alright, now that we have talked about some of the symptoms and risk factors of lymphomas, let's take a look at some objective findings. As we mentioned, fever within the last month is one of the classic B symptoms associated with lymphoma. However, there's also a specific pattern of fever associated with Hodgkin lymphoma called the Pell-Epstein fever. This is a cyclic, intermittent fever that occurs for 1 to 2 weeks before waning. Alright, time to slap those gloves on. A complete physical exam is of utmost importance when working up a patient for Hodgkin lymphoma. First, examine the size and number of palpable lymph nodes. As we previously mentioned, painless lymphadenopathy is one of the most common presenting signs of lymphoma. The lymph nodes are typically round and firm, which we've illustrated here with this round, firm chest piece being moved across the board. Lymphadenopathy most commonly presents in the cervical and supraclavicular regions. However, lymph nodes in the axillary, inguinal, and femoral regions can also be enlarged. Remember that the patient may also have non-palpable lymphadenopathy present, such as in the mediastinum. And remember, lymph nodes aren't the only lymphatic tissues of the body. Assess for splenomegaly. Also, take a look in your patient's mouth and inspect for enlarged tonsils. These are part of Waldeyer's ring, the lymphatic tissue that encompasses the tonsils, base of the tongue, and nasopharynx, and are especially likely to be involved in patients with upper cervical disease. Rarely, patients with more advanced mediastinal disease may present with dyspnea, as well as diminished breath or heart sounds, which could be due to malignant pleural or pericardial effusions. Aquamenti. A bulky mediastinal mass may also cause superior vena cava syndrome. In this syndrome, the mass lesion blocks venous return, causing dyspnea, as well as swelling and erythema of the head, neck, and arms. Again, this is a rare finding. Hodgkin lymphoma is one of the more common malignancies to metastasize to the spinal column, which puts the patient at risk of spinal cord compression. Assess for symptoms of back pain, weakness, incontinence, and decreased sensation. As you can tell, many of the signs and symptoms of Hodgkin lymphoma are nonspecific. Luckily, we've got a few diagnostic tools at our disposal. First of all, check that CBC. Various forms of anemia can occur in the setting of Hodgkin lymphoma, including microcytic, macrocytic, or even immune mediated hemolytic anemia, symbolized as usual by a falling H&H abacus. Various disturbances in the white cell count can be seen as well, especially with advanced disease. This includes leukocytosis or lymphopenia. And the stacked plates are there to remind you of thrombocytosis, again, more common in advanced disease. Eosinophilia is a relatively common finding on the CBC, likely caused by increased production of chemokines that stimulate eosinophil production and recruitment. Lymphomas are also associated with hypercalcemia, usually due to an increased production of 125 dihydroxyvitamin D, though bony disease involvement may play a role as well. All right, let's move on to some diagnostic studies you would consider in a patient with suspected Hodgkin lymphoma. As previously mentioned, Hodgkin lymphoma can coexist with HIV infection. Therefore, patients with risk factors for HIV infection should be tested. The most important first step and definitive way to diagnose Hodgkin lymphoma is through a lymph node biopsy. Excisional biopsy is preferred so that the whole lymph node can be examined. From this sample, several immunophenotype and immunohistochemistry tests will be performed. The histology will determine which subtype of lymphoma is present. Reed-Sternberg cells are the diagnostic feature of classical Hodgkin lymphoma. These cells are large with lots of basophilic cytoplasm, have bilobed nuclei, and have two or more prominent eosinophilic nucleoli, giving them the classic owl eye appearance. These Reed-Sternberg cells are seen over a background composed of lymphocytes, eosinophils, neutrophils, macrophages, plasma cells, and fibroblasts. It's like a densely packed party of little blue nucleated cells back there. To represent all those little blue nuclei you'll see in the background on histology, we've added some blue poops next to Hodgwig over here. The composition of this inflammatory background, as well as the morphology of the neoplastic cells, determines the subtype of Hodgkin lymphoma you're dealing with. Immunophenotyping cells by flow cytometry helps differentiate classical Hodgkin lymphoma from nodular lymphocyte predominant Hodgkin and other lymphomas. Classical Hodgkin lymphoma cells usually express the B cell markers CD15 and CD30, hence the 15 and 30 Roman numerals incorporated into Hodgwig. Immunohistochemistry can be used to detect EBV, kind of like the stains being left behind by this glass of Epstein butter brew. Detection of EBV can help differentiate classical Hodgkin lymphoma from other lymphomas that are typically EBV negative. I also want to briefly mention the rare nodular lymphocyte predominant type of Hodgkin lymphoma. It has a characteristic cell seen in pathology called the popcorn cell because the nucleus looks like an exploded popcorn kernel. In patients with mediastinal disease who present with a symptomatic pericardial or pleural effusion, why not remove some of that fluid for them? Initial management of patients with symptomatic effusions typically involves thoracentesis to remove fluids from the thorax, paracentesis to remove fluid from the peritoneal cavity, or pericardiocentesis to remove pericardial fluid. You're killing two birds with one stone here. Alright, not what I meant. Down, Hodgwig! Jeezy crazy is just an expression. What I meant was the procedure allows you to collect fluid for cytology and diagnosis, while at the same time remove fluid to relieve the respiratory distress. In patients with malignant effusion and respiratory distress, or in patients with malignant diffusion and no easily accessible lymph nodes, this is often the diagnostic procedure of choice. Patients with Hodgkin lymphoma will require a PET CT of the chest, abdomen, and pelvis to help with staging the disease. This is how we determine the proper treatment strategy. So we've drawn in our recurring CT symbol, the black CT cat, as well as a tome of fantastic pets. Required reading here at Hodgworths. Staging uses Ann Arbor classification, which is based on the degree of lymphadenopathy. There are four stages. Stage 1 involves a single lymph node region. Stage 2 involves two or more lymph node regions on the same side of the diaphragm. Notice the crossbeam there resembles the diaphragm. Stages 1 and 2 are considered early or limited stage disease and are further stratified into favorable or unfavorable prognosis for treatment purposes. Essentially, the presence of more sites involved, higher ESR, presence of B symptoms, and a large mass indicate a worse prognosis. Stage 3 involves lymph node regions on both sides of the diaphragm. And finally, stage 4 involves disseminated non-contiguous extralymphatic involvement. So, we've made the number 4 owl flying over to extralymphatic tissues. Stages 3 and 4 are considered advanced stage disease. Now, let's review a quick differential diagnosis. Well, the other side of the coin is non Hodgkin lymphomas, of course, and should be on your differential as well. Both Hodgkin and non Hodgkin lymphoma can occur at any age and are differentiated based on lymph node biopsy. Also, keep acute and chronic leukemias in mind, which can present with constitutional symptoms and lymph node involvement. Your tests of choice here are a CBC with differential, blood smear, and lymph node biopsy. A patient with painless localized lymphadenopathy without a history or clinical presentation suggesting malignancy should be worked up for infectious etiologies. A CBC with differential is obtained, as well as laboratory studies based upon the patient's demographics and exposure history, a few of which are listed in the text. Some autoimmune diseases, such as lupus, can mimic Hodgkin lymphoma. An ANA can be checked if an autoimmune disorder is suspected. And finally, constitutional symptoms without a clear etiology provide an especially difficult dilemma for the clinician. Fever of unknown origin may be evaluated with a range of diagnostic tests, assessing for autoimmune, rheumatic, infectious, and neoplastic etiologies. Again, a few common tests are listed in the text. Now let's summarize the clinical presentation of Hodgkin lymphoma in a sample assessment statement. Mr. Hodges is a 21-year-old male presenting with an intermittent fever and frequent night sweats. On physical exam, he has non-tender lymphadenopathy of his cervical and supraclavicular lymph nodes. A chest x-ray shows a large mediastinal mass. Given his age, presence of B symptoms, and mediastinal mass, the most likely diagnosis is Hodgkin or aggressive non-Hodgkin lymphoma. So how do you treat Hodgkin lymphoma? Early stages, which include stages 1 and 2, are treated differently from late stages, which include stages 3 and 4. Let's talk about the treatment of early stages first. Patients with a favorable early stage disease will typically receive chemotherapy with a 4-drug regimen: doxorubicin, bleomycin, vinblastine, and dacarbazine, also known as ABVD therapy. They usually have an abbreviated course compared to an unfavorable prognosis. We've incorporated a radiation symbol into the window above to symbolize radiation of the involved site, which commonly follows chemotherapy. This combination has the lowest relapse rate. However, if patients choose not to have radiation, they can have more cycles of ABVD chemotherapy. Fortunately, patients with favorable early stage have a high likelihood of achieving complete remission. Patients with late stage Hodgkin lymphoma will also receive combination chemotherapy. Although the combination of ABVD is an option, there are several other combination therapies available, such as the Stanford 5 and escalated BCOP regimens. Radiation is only used for certain patients for consolidation therapy. Patients with late stage disease have a poorer overall prognosis. The International Prognostic Score is used to calculate prognosis based on the total number of 7 unfavorable characteristics at time of diagnosis, which includes several lab values, age, and male gender. As you probably know, chemotherapeutic agents can have some nasty side effects. And monitoring your patient's progress during treatment includes monitoring for these adverse reactions. The A in ABVD stands for Adriamycin, the trade name for doxorubicin. At Sketchy, we symbolize doxorubicin with a heart shaped doxoruby to emphasize the associated cardiotoxicity. All patients should have an echo before starting therapy. The B in ABVD stands for bleomycin, which is associated with pulmonary toxicity. Just think of bleomycin blasting those lungs. The V in ABVD stands for vinblastine, a vinca alkaloid chemotherapeutic agent associated with neurotoxicity. A peripheral neuropathy may present after a few weeks of treatment, manifesting as distal symmetrical paresthesias in a stocking glove pattern. Loss of ankle reflexes and pain and temperature sensation occurs as well. In some cases, motor neurons are affected, resulting in weakness and bilateral foot drop. Radiation can also cause problems. Radiation therapy to the chest and neck can cause hypothyroidism, symbolized by the undone thyroid bow tie, as well as permanent heart and lung injury. Treatment of the pelvis can result in infertility, hence the infertile uterus tree back there. Young female patients should be counseled about fertility preservation. Both chemotherapy and radiation therapy can lead to second malignancies later in life, most commonly breast, lung, or colon cancer. In fact, second malignancy is the leading cause of death in long term survivors. This increased cancer risk continues to rise at least 20 years after therapy, and patients are usually screened for skin and hematologic malignancies at every visit, as well as early screening for breast, lung, and colorectal cancer. Alright, let's recap. Hodgkin lymphoma is a B cell neoplasm that arises from a single mutated B cell, typically in the germinal center of a lymph node, though it can also arise in the liver or the spleen. Disease spreads in a contiguous fashion from node to node. The most common lymph nodes involved are the cervical, supraclavicular, or mediastinal nodes. There are two large categories of Hodgkin lymphoma: classic and nodular lymphocyte predominant. The latter type is pretty rare, so we focused on classic Hodgkin lymphoma. The two most common subtypes of classic are nodular sclerosis, predominating in populations with high socioeconomic status, versus the mixed cellularity type, which predominates in populations with low socioeconomic status. Hodgkin lymphoma has a bimodal age distribution and is more commonly diagnosed in young men. While the most common presentation involves painless peripheral lymphadenopathy, mediastinal masses are common as well, and are typically spotted incidentally on chest x ray. In more advanced stages, patients may present with B symptoms consisting of fever, night sweats, and weight loss. Pruritus can occur as well, while pain with alcohol intake is a rare but specific sign. Although the pathogenesis is likely multifactorial, Hodgkin and non Hodgkin lymphoma are commonly associated with EBV infection. HIV positive and immunocompromised patients are also at higher risk. Hodgkin lymphoma is also associated with some autoimmune disorders. There is also increased risk in patients who have a family history of Hodgkin lymphoma. On physical exam, the prototypical patient has round, firm, painless lymphadenopathy in the cervical or supraclavicular region. Also check for splenomegaly as well as enlarged tonsils, which could indicate involvement of Waldeyr's ring. Signs of pleural or pericardial effusion, as well as superior vena cava syndrome, indicate a mediastinal mass, while signs of spinal cord compression should alert you to the presence of Mets to the spinal column. On labs, you may find various forms of anemia, disturbances in white cell count, or thrombocytosis. Eosinophilia is also relatively common. Increased calcium can occur, usually due to vitamin D production. And for your plan, excisional node biopsy. On histology, we look for those classic allies of Reed-Sternberg cells with an inflammatory background. On flow cytometry, expect the B cell markers CD15 and CD30. And immunohistochemistry can detect concurrent EBV infection. For patients with symptomatic pleural disease or patients with pleural effusion and no obvious peripheral nodes, get a thoracentesis and inspect the fluid for malignant cells. PET CT is used for staging, with stage 1 and 2 localized to one side of the diaphragm, stage 3 on both sides of the diaphragm, and stage 4 disseminated. Early stage disease is typically treated with ABVD chemotherapy, commonly followed with radiation to the involved site. Late stage disease can be treated with ABVD or other chemo regimens. Chemotherapy side effects include cardiotoxicity from doxorubicin, pneumonitis from bleomycin, and peripheral neuropathy from vinblastine. Radiation is associated with hypothyroidism and infertility, as well as permanent heart and lung toxicity. Chemoradiation is also associated with second malignancies, the leading cause of death in Hodgkin survivors. Patients should receive early screening for skin, hematologic, breast, lung, and colorectal cancer. Alright, lunchtime is over. Time to head over to Gurdon and Burkitt's for the non version of the